I'm a final year medical student, and I have interest in obs and gynae, and spent 3 weeks in December in the gynae oncology ward in Nottingham. And yeah, so I'm just going to be going through a few of the gynae cancers, just a few ground rules. If everyone can mute themselves throughout the lecture and use the chat box if they have any questions. And there's going to be a case at the end, so which is going to be an interactive one. So I'm going to ask you guys to just write what you think you want to do in the chat box, if that's okay. And there are polls as well, so which are anonymous. So if you guys want to just have a go yourselves, just as a learning experience. But yeah, so today I'm going to cover cervical, endometrial, and ovarian cancers, and I'll briefly touch on vulval cancers and uterine sarcomas. And yeah, for each one, I'll be going through the definition, the risk factors, the presentation, how would you diagnose and manage the disease. Right. So firstly, just a quick start one. What do you guys think is the most common cause of cervical cancer? You say it's smoking, HPV, nulliparity, obesity, or estrogen. By estrogen, I mean like the use of estrogen. I'll give you guys a few more minutes, a few more seconds. The majority of you answered. Right, on the pause section, then most of you got it right. Yep, so the correct answer is HPV. So the most common cause of cervical cancer is HPV 16 and 18, and those are the ones that we screen for. There are other high-risk cancers, such as 31, 33, well, there's a lot of them, but just a few of them are 31, 33, 35, 52, 56, and normally a persistent infection for over 2 years puts you at high risk for cervical cancer. So one of the biggest screening programs in the UK is for HPV screening. So all HPV screening tests are checking for HPV infection as well as abnormal cytology within the cervix. So you're first invited, all women are first invited for a test at the age of 24 and a half. And between the ages of 25 to 49, they're invited to do it every 3 years. And then after you're 50, up to the age of 65, you're invited every 5 years. And you stop after 65 unless you've recently had an abnormal cytology result, or if you haven't had a HPV screen for a long time and you want to request one, in which case you can. So when the results come back, they can either come back as HPV high risk negative, which is always going to be checked for HPV 16 and 18, and it will give you the cytology results, which is going to tell you if it's cytology positive or negative. So if you have positive high risk HPV and your cytology is negative, then you'll be asked to repeat the smear within 12 months rather than repeating it after 3 years. And if you're HPV positive and you have cytology abnormalities, then you'll be referred for a colposcopy straight away. And this screening has really helped within the years, because from 1990, there's been a 25% decrease in incidence of cervical cancers, but there's been a 75% reduction in mortality of cervical cancers, which is a really good result, I think, overall. Moving on, normally cervical cancers present, they don't normally have a presentation. They're normally found incidentally through the screening program. But if you do have symptoms, they're normally of intermenstrual bleeding or postcoital bleeding, postmenopausal bleeding. And on physical exam, you'll find a rough, hard cervix. And management of cervical cancer will depend on the stage. So there's obviously 4 stages of cervical cancers. First stage is when the cancer is confined only within the cervix. These stages are again broken down into more detail. I'm not going to go into much more detail, so it can get quite complicated. If you guys want to look more into it, you can just Google the FIGO classification, and you'll find out that there's stage 1A, 1B, 1A1, 1B1, and it's quite a lot. But just as simply, stage 1 is only in the cervix. Stage 2 is when it's in beyond the uterus, but not in the pelvic wall so far, or the lower third of the vagina. Stage 3 is when it invades the vaginal wall. And stage 4 is when it's outside the true pelvis. And normally the treatment for this is, it responds quite well to chemo radiation. And sometimes you can do a hysterectomy or surgical resection. Right, we'll move on to ovarian cancer now. So which of the following reduces the risk of ovarian cancers, do you think? Is it pregnancy, combined oral contraceptive pills, your age, so as you get older, HMPCC, or IVF? Again, these are all anonymous, so if you guys just want to take a guess, if you're not sure, you can just have a go at it. I'll end the polls there. Right, the answer is actually pregnancy. So with ovarian cancer, the most common risk factors is anything that anything that increases the number of ovulatory cycles, such as nioparity, early menarche, or late menopause, will increase your risk. So if you're pregnant, obviously the number of your menstrual cycles will decrease, giving you protection against it. There are other risk factors, so BRCA1 and BRCA2 genes, which are also linked to breast cancer. So that's why you commonly associate breast and ovarian cancer. So if you have breast cancer, normally you check the patient to see if they have any risk factors for ovarian cancer, or if they have any presentations for that. Again, family history due to the BRCA1 and 2 gene. Like I said, increasing in menstrual cycles, and also lifestyle factors. There are some suggestions to say that tobacco, obesity, and sometimes asbestos use is linked to it, but there's not as much linked to it as much as BRCA1 and nioparity and things like that. And when we talk about ovarian cancers, there's normally, you can split it up into 2 types. The most common being epithelial carcinomas, which make up for about 90% of the cancers. And you can have non-epithelial cancers, which are your germ cell, your stromal cell, or your sex cord. Today, I'll focus mainly on epithelial carcinomas. Your germ cell are your really weird and wonderful ones, which can present with teeth growing out of anywhere of the tumor. So you can have a tumor on your liver with teeth or hair in it, and but they're very rare. So when you have ovarian cancer, the reason that ovarian cancer is the most common gynecological cancer, and it's the most deadly because of the fact that it has such non-specific symptoms on its presentation. So normally the patient will present with abdominal distension or bloating or pelvic pain or increased urinary urgency. And if they have late presentation, then they'll have some sort of ascites or anything like that. This is for the epithelial ones. And like I said, for the germ cell ones, you can have anything like such hair, teeth, skin, cartilage growing in the tumor, which can present in any location in your body. So it can be in your lungs, liver, anywhere. Right. So when we're talking about the diagnostic factors, does anyone know the cancer markers for ovarian cancer? I'll launch pause. Is it CA 19.9, 15.5, AFP, CEA, or CA 125? Majority are getting this one right. Could be a few more minutes. I'll end the pause there. And yeah, so most people got it right. The most commonly used marker is CA 125. So CA 125 is the most specific for ovarian cancer, but it doesn't mean that it's 100% sensitive. So CA 19.9 can be used in ovarian cancer for mucinous ovarian cancers, but you don't normally test for it. 15.3 is used for breast adenocarcinoma. AFP, which some of you went for, is used more for hepatocellular or testicular cancer. And CEA is a marker for colorectal cancer. So after you've done your CA 125 and you normally you send the patient for an ultrasound and a CT. And if you've managed to diagnose the patient with ovarian cancer, you again stage them depending on the FIGO staging. So stage 1 is when it's limited to the ovaries. Stage 2, again, similarly limited to the pelvis. And stage 3 is when it's limited to the abdomen. And stage 4 is when you have metastasis outside of the abdomen. So most commonly is the lungs or pleural cavity. So majority of the cases that you see are stage 3 and above because of the late presentation for ovarian cancers. And normally for stage 1 cancers, you can just use adjuvant systemic chemotherapy. For stage 2, you can do surgical resection of the tumor, and normally you do a hysterectomy with lymph node resection. And then you can also use adjuvant or neoadjuvant chemotherapy. For stage 3, you do primary cytoreductive surgery. So you're removing all the adnexa in the pelvis, so uterus, ovaries, and you're connecting the you're removing all of the adnexa, and then you're going to resect all of the lymph nodes. The main lymph nodes you need to be careful to check for is a para-aortic. You'll also resect the whole lining of the abdominal cavity because there's a lot of lymph nodes there which are normally have the metastatic diseases. And for stage 4, again, you can do surgery, but normally it's palliative care because when it's within the lungs, it's really hard to resect the cancer from there, and the survival, 5-year survival for stage 4 cancer is less than 20%. And you can also do the risk for malignancy index, so the RMI, which basically looks at two things: your ultrasound score, your menopause status, and your CA-125 markers. So your ultrasound score is basically you're looking at the number of cysts or solid areas that you can see. That's graded from 1 to 3. So yeah, 1 to 3. And then if you're postmenopausal, you get 3 points. If you're premenopausal, you get 1 point. It's a bit weird. And then you times that by your CA-125 marker. So positive CA-125 is normally more than 35, but normally patients who present with ovarian cancers have up to 3 times the normal CA-125. So if you see anything above 90, then it's something to be worried about, and you should refer to gynecology. Right. Now moving on to endometrial cancer. Which of the following is a protective factor for endometrial cancer? I'll give you guys another 15 seconds. So big spread of answers here. All right, I'll end the pause there. Right. So the correct answer here actually is the combined oral contraceptive pill. So the endometrial cancer is the most common uterine cancer, with the risk factors being menopause, so postmenopausal, nulliparity, PCOS, obesity, and Lynch syndrome. Lynch syndrome, does anyone want to write in the chat what other cancer is Lynch syndrome associated with? Yeah, perfect. It's colorectal cancer. So with endometrial cancers, there's 2 types. There's adenocarcinoma, which is the most common one. And then type 2 is also known as high-grade endometrial cancer. So if you hear your consultant say high-grade endometrial cancer, they're referring to one of the 3. So adenosquamous, clear cell, or papillary serous. Again, just for today, I'm going to focus mainly on adenocarcinoma. Right. So normally, patients with endometrial cancers will present, they are postmenopausal. So normally, they'll present with postmenopausal bleeding. If they are premenopausal, they can have persistent intermenstrual bleeding or really heavy menstrual bleeds. And if they present with advanced diseases, then you have abdominal pain, distension, bloating, and changes in your bowel habits. And NICE recommends that if anyone over the age of 55 presents with abnormal discharge or visible hematuria, they need a transvaginal ultrasound. So when you're trying to diagnose endometrial cancer, you have to do a transvaginal ultrasound. And if the thickness of the lining of the endometrium is what's measured. If the patient has postmenopausal bleeding, is not on HRTs, and there's more than 4 millimeter thickness, then you need to do a biopsy. And if you cannot do a biopsy for any sort of reason, then a hysteroscopy should be done. And that biopsy will tell you the type of cancer. And you can also do CT for the metastasis. Again, management-wise, it depends on the staging. So stage 1 is when it's confined to the uterus. Stage 2 is when it extends to the uterine cervix. Stage 3 is beyond the uterus. And stage 4 is when it's invaded the neighboring organs or has distant metastasis. And normally the baseline treatment is total hysterectomy and bilateral salpingo-oophorectomy without removing the vaginal cuff or a paramectomy. So with low risk cancers, you do not need adjuvant therapy. But if you have a high to intermediate risk endometrial cancer, so stage 2 or 3, you can do adjuvant brachytherapy or external beam radiotherapy. And for high risk endometrial cancers, you do external beam radiotherapy with concurrent and adjuvant chemotherapy. Now, if we're talking, I'll quickly mention the rarer cancers. So these ones are not commonly present, like you won't commonly see them, but there may be a chance. So vulval cancers. So normally this presents in older patients that are postmenopausal, or those that have immunosuppression. And lichen sclerosis has had that has quite a high risk for vulval cancers. Also, patients with HPV have a risk for vulval cancer. When patients present with vulval cancer, they have some sort of external bleeding, or they present with ulcerations around the vulva. And normally it's the labia majora that's involved rather than anything else. And it normally has an irregular mass. You might be able to see some, like an ulcer that's bleeding or a lump. And before the cancer, you can have something called you can have VIN called vulval endothelial neoplasia, which is the premalignant condition which affects the squamous epithelium. And so diagnosing for vulval cancers is normally just by a pelvic exam, and then you have to do, when you see the ulcer, you have to do a biopsy of the lesion, and you can do sentinel lymph node biopsy as well at the same time. And management will have to be resection of the excision of the vulva and the lesion, as well as lymph node dissection. So I mentioned about endometrial cancers. So uterine sarcoma is another cancer that affects the uterus, but this is quite rare. And it can be a leiomyosarcoma, endometrial stromal sarcoma, or adenosarcoma. And normally this happens post-radiation, or if you've had tamoxifen treatment from breast cancer. So these patients, again, present with abnormal bleeding, or they can have a mass in the vagina or abdominal pain. And diagnosis is by a physical exam with a vaginal exam, and you'll feel a hard mass within the uterus. And then you can do a dilatation and curettage to remove a part of that sample and biopsy it, or you could straight do an endometrial biopsy. And these are normally managed by laparotomy or hysterectomy to remove the lesion. Right. And now this is where I'm going to need you guys to get your chat boxes up, and we'll walk through a case together. So imagine you're a GP and a 62-year-old woman presents to you with 2-month history of feeling full, and she says she cannot button her trousers recently. She says she has started to skip lunch recently, which is not common for her, and her bowel and bladder movement have been normal. As a GP, what are the questions you want to ask her? Any bleeding? No, she's not had any bleeding. No abdominal pain, but she says she just feels like heavy. Weight loss, she thinks she may have had some weight loss, but she's not sure. She doesn't really measure it often. But she says that she's struggling to button her trousers though. But she feels like her face got thinner. Nausea and vomiting, not really. Discharge, no discharge or no lumps. No, her bladder and bowel symptoms are working fine. No symptoms for that. No dyspareunia either. So she says that she thinks she's lost weight, but she finds that recently she's just struggling to button her trousers. She's postmenopausal. She says she's had some vaginal spotting, but nothing heavy, no heavy bleeding. Contraception history, she's not using anything right now. Let's move on to what test would you want to do? Fertigani for endometrial ultrasound, okay. Anything else? CA125, perfect. What else would you want to do with the CA125? Perfect, Raj. So yeah, this patient you'd want to send for, what kind of ultrasounds would you want? Yeah, so you'd want both transvaginal and abdominal ultrasounds. Yep, you can calculate the RMI, but for that you'd have to get the CA125 first. So yeah, perfect, guys. So the first steps here would be, because remember you're a GP, so you'd want to ask for a CA125 and a urgent 2-week urgent referral for transvaginal and abdominal ultrasound. And once they come back, you would have to send her for a 2-week referral to obs-and-gynae. But other than the obvious things, so what would be your initial differential diagnosis? Yep, ovarian cancer. What else? This is before your CA125 has come back. What else can present as ovarian cancer? Yeah, you can suspect endometrial cancer as well, I guess. She has spotting, yeah. What other benign conditions would you think can present as ovarian cancer? Yes, because she's been struggling to do a button up, you could potentially think of ascites. So with the not being able to do the button up, that's really perfect fibroids. That's what I was looking for. So coming back to what I was saying about not doing the button up. So that's a really common thing that GPs get presented with. So a patient will come in saying that I haven't gained weight, but I've really been struggling to do my bottom up. It's because they feel bloated and they have their abdomen is distended, but they can't explain it properly. And you may have seen posters if you have been in your gynae rotations that says, are you struggling to close your trouser buttons? If so, then mention to your doctor. It was a really famous campaign. I'm not sure if you guys have heard of it. Right. So you do your CA125 and it comes back as 240. What would be the next best imaging? I think we've been over that. Pelvic and abdominal ultrasound. Yep, perfect. So this comes back as a 6 centimeter mass on the right ovary and a 2 centimeter mass on the liver. What stage would you classify this patient? Stage 4. Right. Any other guesses? Yeah, this is stage 3. Remember, guys, stage 4 was when it's outside the abdominal cavity. So stage 4 is when you have metastasis in your lung or pleural cavity. Sometimes it can, very rarely, it can be in your brain, but normally they present within the lungs or, yeah, chest. Right. And how would you want to manage this patient? Right. So, yeah, debulking surgery. Before that, would you want to do any imaging? Yeah, MRI or a CT? So why would you? Yeah. Staging CT, perfect. So because the main issue with ovarian cancer is your lymph node metastasis, so it's really important to do a CT so you know before you go into surgery which lymph nodes you're looking for, because sometimes you can see them quite obviously on the CT. And because she has a liver mass as well, it's important to know where that mass is and what approach you need for that. So yeah, most you want to do is cytoreductive surgery with lymph node resection and adjuvant chemotherapy as well. What would you think the 5-year survival rate for this patient would be? Just take a guess if you guys want. Years. Oh, I meant percentage. 5 years survival rate. 5%. Remember, for stage 4, the 5-year survival rate was about 20%. So for stage 3 cancers, you normally think about 30 to 45% approximately. Obviously, this is just a prediction. Some people do live a lot longer, and some people do, unfortunately, do not make the 5 years.